Okay. See. uh, Let us discuss with the first question here in the for the subject of oral pathology. So this is a November 2023 INICET paper. Now here the first question says that the term enameloma refers to. See, basically, enameloma means, if you see here, I'll draw a diagram for you people. Suppose this is a tooth. Sorry. Suppose this is a tooth. At the area of furcation, you will see a globule of enamel. So it is nothing but an ectopic enamel actually. So this is ectopic enamel. Normally we don't see enamel on the root. Here at the furcation area we are seeing some ectopic enamel. That ectopic enamel is known as enameloma. Actually it is not. Normally what we think oma means tumor. It is not any tumor. It has got nothing to do with any tumor. It is not a neoplasm. It is just an ectopic deposit, tiny globule or a deposit of enamel which is found on the root at the furcation area. So this is very important one. That's what the fourth option is correct here, that it is a tiny globule of enamel that arises from a small group of misplaced ameloblasts. This is very important. So basically we know that enamel is formed by a cell called as ameloblasts. So some of the ameloblasts during the formation of the root, they will get displaced or misplaced. They change their position. So that once they change their position, their function is to produce the enamel matrix. So thereby they start producing enamel matrix and finally an ectopic enamel at the furcation area. This is known as the enameloma. Okay, next. A 24-year-old woman presents to a clinic with painful ulcers which rapidly progressed. So here the question says that first of all woman, and most important ulcers which are painful. So by that, see, whenever they give a clue, the clue first thing what you have to find out is whether ulcer is painful or painless. Here they have given a history of a painful ulcer. Okay, then which rapidly progressed. Histopathology revealed ballooning degeneration of the epithelial cells and Lipschutz bodies. All of us know that ballooning degeneration of epithelial cells or balloon cells and Lipschutz bodies are typical of herpes. So here let us understand some important point that in herpes, the ulcers that you see are always, remember, they are painful ulcers. Ulcers that you see here are painful ulcers. And secondly, what you have to remember that there is something called as, see, we know that it's a virus. It's a virus. Now virus, whenever viral infections, they affect the whenever a viral infection affects a epithelial cell, what this virus will do, it will cause certain changes within the cell. Those changes are known as cytopathic effect. So a virus infects an epithelial cell because of this infection, the epithelial cells will undergo certain changes. Now, what are those changes? The epithelial cells will become swollen like this. Those are called as balloon cells. Balloon cells. Okay. And they have a chromatin margination. If you see the nucleus is made up of chromatin. So their nuclear chromatin will be marginated. And they will show Lipschutz bodies. So what are Lipschutz bodies? Lipschutz bodies are something but the intranuclear inclusion bodies. So these are the inclusion bodies that you see. Basically, what are inclusion bodies? These are the viruses which multiply within the host cell. Virus material or virus particle which multiplies within the host cell is called as inclusion body. And here in herpes we see an inclusion body called as Lipschutz bodies. So based on that, the diagnosis is herpes. So always remember, the question itself will give you on most of the times an answer. Painful ulcers, presence of ballooning degeneration of epithelial cells, that is balloon cells, and Lipschutz bodies are characteristics of herpes. Okay, so that is about the second question. Let us move on to the third question here. Bilateral expansile mandibular lesion is characterized by. This is a very simple single liner MCQ which has been repeated multiple times. See here, among these, if you see Paget, polyostotic fibrous dysplasia, Cherubism, giant cell granuloma, all of us know Cherubism. Okay, but there are certain peculiarities you have to remember about the Cherubism. First of all, Cherubism is autosomal dominant. All of us know it is autosomal dominant. It is bilateral. That is the uniqueness. It affects both the sides. Mandible. Initially it affects mandible. Later it spreads to even involve the maxilla also. Okay. So it's a bilateral expansile lesion. So here you have to remember that it is expansile means it is even having radiolucency. Multilocular radiolucency. So the point you have to remember that this Cherubism typically has got multilocular radiolucency, that too bilaterally, and it is expansile. So the lesion is expansile. What do you mean by expansile? The bones are expanding. That is the reason why, as the maxilla is expanding, the eyeball rotates upwards. That is why they call it as eyes up to upwards to heaven appearance. So it appears as if the child is looking up to the heaven. Eyes are rolled that way. Okay, that is a unique point of the Cherubism. And this Cherubism is here. That is why they call it expansile. Maxilla is expanded. Okay, even mandible starts with mandible. Mandible is expanded. Except remember, all parts of maxilla and mandible are affected by this Cherubism except condyle. So remember, condyle is never affected with the Cherubism. Condyle is never affected. Here what we have to remember is condyle is never affected by Cherubism. That's a point you have to remember about this. Now let us move to the fourth question. Identify the diagnosis in a male patient with a tongue lesion enlarging progressively. If you typically see this lesion here, typically the tongue is enlarged. So whenever we see tongue enlargement, it could be hemangioma, it could be lymphangioma. But for hemangioma, tongue is not the most common sign. For lymphangioma, tongue is the most common sign. And if you see carefully, see the lesion, how the lesions are. They are multiple small lesions which are like fluid filled. Okay, so typically this gives rise to something called as frog egg appearance. Frog egg appearance is a typical of lymphangioma, where the tongue is enlarged. It appears as if a tongue is filled with the tongue. You can see multiple small fluid filled blisters. If you see radiograph, there is no clue here. Radiograph is totally normal. So this is a typical case of lymphangioma. On the other hand, hemangioma does not occur most commonly on the tongue. It most commonly affects lips. Hemangioma, most common soft tissue site is lips. Lymphangioma, most common soft tissue site is tongue. Okay. Hemangioma can have radiographic features. Remember, hemangioma can affect mandible. Posterior mandible is the most common site. But lymphangioma usually does not affect the jaw bones. Intraorally, tongue is the most common site. Sometimes what happens is lymphangioma also appears in the lateral side of the neck in infants. That is why it's there where you call it a cystic hygroma. Lymphangioma is known as cystic hygroma in infants, where it affects the entire lateral neck. Okay, so that is a point you have to remember about the lymphangiomas. So these are the points you have to remember. Yes, pebbly vesicles, very good. Pebbly vesicles are seen. That is called as the frog egg appearance. Okay. Which of the following tumor develops from odontogenic myxoma? From odontogenic mesenchyme. We know, all of us, in the classification, WHO classification of odontogenic tumors, that odontogenic tumors can arise exclusively from epithelium, exclusively from mesenchyme, or combination. Exclusively from mesenchyme, we have two things. One is odontogenic myxoma, one more is the cementoblastoma. So correct answer is 1 and 3. 1 and 3. So 1 and 3 is typically seen in option. Okay. Why? Because odontoameloblastoma and AOT are all like, they are not this one. AOT is so typically epithelial. But odontoameloblastoma, this no concept is now obsolete. Is now that obsolete. Okay. So they say many of the times there is no such tumor at all. So it is a bit controversial tumor. Not tumor as such. It is basically a hamartoma. It is controversial. It is not exclusively mesenchymal. Because ameloblastoma is coming. The word ameloblastoma is coming. Ameloblastoma is purely epithelial. Odonto is connective tissue. So it is mixed. So if I have to write down, I'll write down that this is purely epithelial. This is mixed, whereas the 1 and 3 are basically mesenchymal in origin. 1 and 3 are purely mesenchymal in origin. Okay, let us move to the next question here. True microdontia of maxillary lateral incisor is known as peg laterals. This is straight, simple liner MCQ. I need not give any explanation for that. Microdontia of maxillary lateral incisor is known as peg shaped lateral. So what is the definition of a peg shaped lateral? Any lateral incisor if its width is narrower near the incisal edge. So this is an incisal edge. So incisal edge, you will be narrower compared to the cervical region. So if you take the cervical region, it is broader compared to the incisal region. That is nothing but your peg shaped laterals. Okay. Which of the following contains all three germ layers? All of us know teratoid cyst. See, basically, hamartoma is not like all the three germ layers. Hamartoma is basically ectopic tissue which is arising. The proliferation of the tissue cells are occurring from proliferation of the cells native to that place. If it is ectopic, it becomes choriostoma. If it native, then it is hamartoma. Okay. Dermoid cyst, sebaceous cyst are not actually all of this one. If you see a teratoma, it is a three germ layers. Teratoid cyst actually, which is nothing but a derivative of same thing, which arises from all the three germ layers, is known as the teratoid cyst. So sometimes they give teratoid cyst, sometimes they give teratoma. So you have to be carefully. So that teratoma is nothing but any this one malformation, developmental malformation, which is arising from all the 3 germ layers, is known as a teratoma. Identify the following abnormality. If you see carefully in this case, the teeth, if you see, so if you, I'll just zoom for you, you can see the, 1 second, sorry. If you see carefully, this tooth and this tooth, one tooth are fused with the other. This is simple fusion. If you see the count the number of the teeth, the number of teeth are less in case of fusion. Okay, so this is a typical example of fusion. You have to remember, where in the fusion you will see one tooth will be less compared to the number, if you see, because there is a fusion of the 2 teeth here. So in this case, there's a typically fusion between the lateral incisor and the canine. Nikolsky sign is absent in. So what is Nikolsky sign? After all, Nikolsky sign is nothing but a important dermatological sign, where whenever there is the tangential pressure is applied on the adjacent tissue, wherever there is the lesion, the skin around the adjacent tissue, if you apply tangential pressure, there is a peeling of the epithelium or loss of the epithelium. That is called as Nikolsky sign. So Nikolsky sign is very important sign. Remember, all types of Pemphigus will show Nikolsky sign. All type of Pemphigus will show Nikolsky sign. Epidermolysis, your erythema multiforme shows Nikolsky sign. Okay, a type of pemphigoid which affects the oral cavity or the conjunctiva, that is mucous membrane, or cicatricial effects is characterized by Nikolsky sign. Remember, the one type of pemphigoid which does not affect the oral cavity or mucosa is bullous pemphigoid. So bullous pemphigoid affects exclusively skin, and this is a type where you will not see Nikolsky sign. So Nikolsky sign is negative in bullous pemphigoid. All other types of pemphigus, remember, generally all types of pemphigus will show Nikolsky sign positive, and one type of pemphigoid, that is cicatricial pemphigoid or mucous membrane pemphigoid, will show the Nikolsky sign positive. Nikolsky sign positivity. So this is about the Nikolsky sign. I hope all of you are clear about this Nikolsky sign. So there is one more important sign, if I have to tell you, that is called as Asbo-Hansen sign. What is Asbo-Hansen sign? Asbo-Hansen sign is very simple. It is very simple here. What it is also known as blister spread sign. Blister spread sign. What do you mean by that? If there is a blister, and if you apply pressure on the center of the blister will expand or spread in equal directions, equal in all the directions. That is called as blister spread sign or Asbo-Hansen sign. That is again a feature of these skin diseases, particularly the pemphigus. So that is about the Nikolsky sign. Now let us move on to the 10th question. True about Garre's osteomyelitis. So first of all, what is Garre's osteomyelitis? Let us understand. It's a type of osteomyelitis, all of us know. It is also known as chronic osteomyelitis with peripheral periostitis. Okay, so typically if you see the periosteum, which is there on outside of the mandible, it has got layers in these patients. So it is like a periosteum is deposited like this. This is called as onion skin appearance. So radiographically you will see onion skin appearance. So what is true here? The question they are asking is, what is true? So there are many things which are false here. There is only one thing which is true here, that it is seen in immunocompromised patients. No, Garre's osteomyelitis has got nothing to do with the immunocompromised patients. It is seen in children and young adults. Yes, That is the one which is important. Has moth eaten radiographic feature? No, I have already discussed that there is a periosteum which is duplicated. Duplicated means periosteum is deposited one over the other. That is called as onion skin appearance or onion peel appearance. Okay. Causative organism is Staphylococcus. That is wrong. Garre's osteomyelitis is the one where that is the uniqueness of that. It is not caused by the it is not actually caused by the Staphylococcus. It is caused by the other organisms. Like for example, actinomyces is involved in case of Garre's osteomyelitis. Consider the following: odontogenic keratocysts, calcified falx cerebri, short metacarpals, enlarged head circumference. Which of the following features given are seen in case of nevoid basal cell carcinoma? So first of all, nevoid basal cell carcinoma means it is also known as the Gorlin-Goltz syndrome. It is also known as Gorlin-Goltz syndrome. So what is Gorlin-Goltz syndrome? It is a syndrome where the patient will have the multiple OKCs, and the patient will have the center of the if you see the skull, the falx cerebri will be calcified falx cerebri. Okay, so that is why you have to see that the option 1 is correct here. That 1 and 2 are the one which are correct in case of the nevoid basal cell carcinoma syndrome, also known as the Gorlin-Goltz syndrome. Next, let us move on to the 12th question here. Riga-Fede disease is associated with. What is Riga-Fede disease? Typically in case of an infant, where there is a natal and neonatal teeth. What do you mean by natal teeth? The teeth which are present at birth. Normally, first tooth that has to erupt is at 6 months of age. That is mandibular central incisor. Here in these patients, what happens is sometimes you will see the teeth in the mandibular incisor area only, small teeth at birth itself. They are very sharp. They will cause trauma to the infant's tongue, that to ventral surface of the tongue. So on the ventral surface of the tongue, you will see an ulcer. That ulcer that is seen on the ventral surface of the tongue due to the natal and neonatal teeth is known as Riga-Fede disease. So Riga-Fede disease is mainly because of the natal teeth. So the location of the ulcer is important here. The location of the ulcer is ventral surface of the tongue. So tongue has got different areas, all of us know. Dorsal surface, lateral border and all those things. Ventral surface of the tongue is the area where you will see the ulcer. That is nothing but your Riga-Fede disease. Okay. Now male with an extra X chromosome, most commonly seen with. Now here the question they are seeing is, all of us know one extra X chromosome is seen in males is in the Klinefelter syndrome. So basically, normally we know that males have got XY, whereas sometimes what happens is sometimes there is an extra X chromosome that is called as a Klinefelter syndrome. In Klinefelter syndrome patients, typically you will see taurodontism. Okay, so all of us know taurodontism is actually a phenomenon where you will see that the bifurcation of the root is displaced apically. So apically it is displaced. Normally you will see furcation in this area. This is a furcation area. Usually you will see here there is apical displacement of the furcation area or the pulpal floor. That apical displacement of the furcation area or apical floor is known as the taurodontism, or it is also known as bull teeth. Remember, taurodontism is seen in typically you will see this in Klinefelter syndrome patients, Down syndrome patients. In Down syndrome patients also you will see the You will see this extra X, that is a Klinefelter syndrome. You will see this, and Down syndrome. You will see the Taurodontism. So Taurodontism is nothing but the clinical. It's basically a radiographic image. Remember, it is a radiographic image. When you take a radiograph IOPA, you will see that a very large crown and the furcation area is totally shifted apically, very small furcation. Okay, small roots. That is why it is known as a Taurodontism or bull teeth. Let us move on to the next question. Which of the following pre-malignant condition has highest potential to become malignant? See, basically there are 4 options here: PVL, speckled leukoplakia, lichen planus, tobacco pouch keratosis. First of all, tobacco pouch keratosis I'll rule out because this is not pre-malignant at all. The other 3 is there, that too in case of lichen planus, not all types of lichen planus, only erosive type of lichen planus is basically the pre-malignant. So among the 3, if you take, PVL is the one which has got highest malignant transformation rate, that to 70%. So remember, the PVL, proliferative varicose leukoplakia, has got a high malignant transformation rate. There are multiple white patches in the oral cavity. In these patients, typically there are multiple white patches in the oral cavity. And if you carefully see and if you elicit the history, ask the patient, are you a tobacco chewer? Are you a tobacco smoker? The patient will say no. Typically a woman patient who doesn't have this tobacco chewing, tobacco smoking habit, multiple white patches are seen. That is a characteristic image or characteristic features of PVL, proliferative varicose leukoplakia. And you should be very careful. You have to educate the patient. There is a high risk that those white patches can get transformed into malignancy. So malignant transformation rate is very high. It is around 70%. So sometimes the malignant transformation rate, you should remember range and average. Range is 30 to 100%. Sometimes what happens is even 100% of the cases there will be malignant transformation. Range is 30 to 100. Average, that if you see malignant transformation rate, is 70% in case of PVL. Speckled leukoplakia and all, they are very less. Okay, speckled leukoplakia and are very less. And then you have the lichen planus and all those things. Speckled leukoplakia is also known as a nodular leukoplakia. Please remember, there is another name for this speckled leukoplakia, where you will see red and white patches together. Red and white patches. Normally, if you see white patch, you are going to call it as leukoplakia. And if you see exclusively red patch, you are going to call it as erythroplakia. If you see combination of the two, you are going to call it as nodular leukoplakia or speckled leukoplakia. Speckled leukoplakia, where again the malignant transformation rate is very less. Okay, it's around 2% somewhere. You will see in case of the nodular leukoplakia. Okay, let us move to the next 15th question. Low grade salivary gland malignancy among the following tumors. If you see, the question they are asking is low grade salivary gland malignancy. So it's a malignancy. Is pleomorphic adenoma malignancy? No. So clearly I can rule out it is not. Actinic cell carcinoma is a malignancy. Adenoid cystic carcinoma is a malignancy. Canalicular adenoma again is a benign tumor. It is not malignancy. So there are 2 malignancies. Among the 2, one is low grade, one more is high grade. So this is low grade, and remember always adenoid cystic carcinoma is high grade. So this is a very important single liner MCQ that frequently comes in the paper of oral pathology, for the subject of oral pathology: high grade and low grade salivary gland malignancies. Okay, actinic cell carcinoma is a low grade malignancy. Adenoid cystic carcinoma has got typical high grade malignancy with a perineural invasion. Adenoid cystic carcinoma has got a tendency for perineural invasion. Okay. Next, patient with a disorder characterized by presence of Philadelphia chromosome and gingival lesions is CML, chronic myeloid leukemia. So we know that Philadelphia chromosome is a chromosome, and there is a translocation. There is a translocation of the chromosomal material. Okay. Again, the single liner MCQs. Oral myiasis is most commonly seen in which countries? All of us know it is oral myiasis is a very deadly disease, very endemic in property, particularly in some countries, particularly in India, subcontinent of Asia, particularly in India, where you will see that larvae, these are larvae, myiatic organisms, which you see typically that comes out from the skin. Okay, that is called as oral myiasis. So in the oral cavity also you will see this oral myiasis, particularly gingiva. So I have seen personally by myself 2 cases of oral myiasis where if you, it's a very pathetic sight actually. The patient, as soon as you see the open the mouth from the gingiva, you will see the small larvae coming outside. There is myiatic organisms. That is why it's called as oral myiasis. So you remember gingiva is the most common site where you will see the oral myiasis. Okay, moving on to the next question. A 35-year-old female patient presents with a complaint of burning sensation, persistent burning sensation in her mouth, which intensifies when eating spicy food. So always there is burning sensation, and when the patient eats some spicy food, there is more burning sensation. On examination, there are irregular, red, smooth, depapillated patches on the dorsum surface of the tongue. So on the tongue, you will see the depapillation. These patches display a serpentinous map-like pattern with a white border. There are no signs of infection or systemic disease. What is your diagnosis? See, if you see, basically, there are 2 things here. One is, from the first part, they have confused. As soon as you see burning sensation of the mouth and the patient is on eating spicy food, what will come to your mind? OSMF, there is oral submucous fibrosis. But later when you see the clinical lesion here, characteristically, there is a depapillation of the tongue and there is serpentinous pattern that you see, that is typically a geographic tongue. Remember, there is so much of depapillation of the tongue. Tongue is depapillated, but patient doesn't have any complaint with the tongue. Tongue, there is no burning sensation. Burning sensation of the mouth might be seen and all those things, but just to confuse you, they have given. So remember, there is a depapillation of the tongue. There is serpentinous. There's what that's typically they call it serpentinous. White borders with serpentinous. That means map-like. You will see snake-like. Serpentinous means snake-like. Serpent. A 26-year-old male patient presents to your clinic with a complaint of persistent ulcer on the inside of his cheek. He had a history of chewing tobacco for several years. On examination, ulcer is found to be non-healing, irregular shaped and measures approximately 2 cm in diameter with palpable submandibular lymph nodes. Excisional biopsy revealed keratin pearls with downward projection of the epithelial masses. What will be the diagnosis? Typical. See, there are so many points. First of all, non-healing ulcer. Patient is a tobacco chewer. Tobacco chewer, non-healing ulcers, lymph node metastasis is there, keratin pearls are there, and there is a history they are saying, and there is a clue they are giving that the epithelium is entering into the connective tissue. There is invasion. So all these are typical features of the squamous cell carcinoma. If you see carefully, the answer is squamous cell carcinoma. You can see this is an ulcer which is non-healing ulcer, and the clue that they have given here is that the squamous cell carcinoma basically will has got 3 differentiations: well differentiated, moderate differentiated, poorly differentiated. Obviously this could be what kind of differentiation you can see. Exactly I can't say, but whenever I see more of keratin pearls, I can suggest that it could be well differentiated. Whenever there are more keratin pearls, it is a clue that it could be a well differentiated squamous cell carcinoma. Let us move on to the next question. A patient complains of inability to open the mouth and has a sensitivity to spicy food. Simple stressmus is there, burning sensation is there. Patient has got fibrotic bands on that are palpable here. The best diagnosis is OSMF. All of us know, very simple, nothing to explain this. OSMF, typically the patient complains of trismus, inability to open the mouth. And remember, trismus is maximum whenever there is a fibrosis in the retromolar area. So whenever there is fibrosis in the retromolar area, the patient has got more severity of the trismus. Otherwise, the patient will have burning sensation, which is considered to be the earliest sign. Remember, earliest symptom of a patient of OSMF is burning sensation of the mouth. Auto-inoculation is seen in. What do you mean by auto-inoculation? Actually, the question is wrong here. Papilloma doesn't show auto-inoculation. In fact, actually, Verruca vulgaris will show auto-inoculation. Okay, but still, we'll go with this papilloma only. Now, what is papilloma here basically? What is auto-inoculation first of all? Auto-inoculation means, for example, if a patient is having a papilloma at the angle of the mouth, if the person touches with his bare hands the papilloma, and if he touches somewhere else in the oral cavity of the skin, the new lesion will develop that area. That is called as auto-inoculation. Same patient, one more lesion will appear. That is called as auto-inoculation. Remember, auto-inoculation is typical of the patients of Verruca vulgaris. Actually, it should be Verruca vulgaris, not papilloma. But remember, they have not given in the option Verruca vulgaris. Go with papilloma. Why? Because Verruca vulgaris is simple skin counterpart of papilloma. Papilloma affects the oral cavity. If it affects the skin, you are going to call it as Verruca vulgaris. Okay. Dentinogenesis imperfecta is an autosomal dominant disorder. All of us know. Which of the following chromosome is related to its that means the location of the gene. So we know that DSPP gene, dentine silophosphoprotein gene, is the one. DSPP gene, that is a gene here that is mutated in case of the dentinogenesis imperfecta. That is called as dentine silophosphoprotein gene. Let me write down this. Dentine silophosphoprotein. So this gene is actually located on the chromosome number 9. So whenever this gene is mutated, the patient will have the dentinogenesis imperfecta. We should also remember that there is one more gene that is mutated in case of the dentinogenesis imperfecta. That is COL1A1 and COL1A2. What is COL? It stands for collagen. Collagen A1 and collagen A2 are the gene which are mutated in case of the dentinogenesis imperfecta. Okay, let us move on to the 23rd question. Below are the risk factors predisposing to carcinoma except. See, all of us know that carcinoma has got certain predisposing factors. What do you mean by predisposing factors? If you see those features or those conditions, characteristically there is a high risk that patient will develop carcinoma. DNA aneuploidy. All of us know what is aneuploidy. Aneuploidy means, see, normally there is a haploid, a diploid. Aneuploidy means the set of chromosomes are abnormal. Okay, they are abnormal. That is called as DNA aneuploidy. So whenever you see DNA aneuploidy, that is a characteristic feature of the carcinoma. Male, female, there is no predisposing factor. Leukoplakia in non-smokers. Yes. Smoking and non-smokers, if you see, compare non-smokers, if you see leukoplakia, that is a high risk for the carcinoma. Invasive candidiasis. Yes, of course. Because candidiasis will produce one carcinogen, N-nitroso-benzyl methylamine. What is the name of carcinogen that candidiasis produces? Is N-nitroso-benzyl methylamine. So by this we can say that the correct answer here is the, let me write down here, male. So gender has got nothing to do with the predisposing factor. Ghost cells in the histopathology is seen with. All of us know ghost cells. What are ghost cells actually? So whenever you see a ghost cell, it is first point you should remember that it is because of the aberrant keratinization. It is because of aberrant keratinization. What is aberrant means? Aberrant means abnormal. So ghost cells are nothing but epithelial cells only, which have got abnormal keratinization. They have got a very faint nucleus. That is why they are called as ghost cells. Normally you see nucleus, blue colored nucleus, right? However, in these ghost cells, you are going to see a cell with a eosinophilic cytoplasm, but the nucleus is blue and very faint, light blue and very faint. That is why it's called as ghost cells. So ghost cells is a typical of COC. Again, this is a single liner MCQ we have discussed many times. That is also known as Gorlin cyst. COC is also known as Gorlin cyst, where you will see this ghost cells. So we are left over with only 3 more questions for today's discussion. The patient has brownish discoloration of the teeth since childhood. Since childhood, the patient has got brownish discoloration of the teeth. Radiographic features involve obliteration of the pulp. Gene associated with this disease. Already we have discussed just now. Dentinogenesis imperfecta. In dentinogenesis imperfecta, you have 2 groups of genes that are defective, abnormal or mutated. COL1A1 genes and DSPP genes. So, in dentinogenesis imperfecta, what happens basically? In dentinogenesis imperfecta, you will see abnormal deposition of secondary dentine. Secondary dentine that you see is abnormally deposited. So because of so much of increased deposition of this secondary dentine, abnormal secondary dentine, the pulp gets obliterated. You will not see pulp space at all. That is why when I will take a radiograph, IOPA, I cannot see any pulp space at all in case of dentinogenesis imperfecta. Okay, so this is a typical feature of the dentinogenesis imperfecta. So let us move on to the next question here. 26th question. A 50-year-old female reported to a clinic with multiple painful vesicles, erythematous condition in her skin. Histopathological smear showed acantholysis in the basal layer. Autoantibodies are directed against desmoglein. Typically, it's a patient of Pemphigus. Because there are 2 things here. Whenever you see a split or a vesicle, first see where is the vesicle, whether it is intraepidermal or septepidermal. Here they are saying acantholysis in the basal layer. That means the basal layer is intact. Above the basal layer, you are going to see acantholysis. So because that is nothing but intraepidermal split or suprabasilar split. It's also called as suprabasilar, above the basal cells. So typically in Pemphigus, you are going to see these suprabasilar split, where above the split, in that split space, you will see small cells. Okay, those are nothing but your Zank cells. Epithelial cells are round. They are round. Typically, if you see, epithelial cells are not round. Epithelial cells are, they have got their own shape, squamous shape. Here, however, in case of the Pemphigus, you are going to see the round acantholytic cells. They are nothing but the Zank cells. And remember, why do you see basically Pemphigus? All of us know one cell is connected to the another cell because of a junction called as desmoglein. So there are 2 types, desmoglein 3, desmoglein 1. What happens is basically in Pemphigus, IgG, that is autoantibody G, is directed against this desmogleins. So because of this, the desmogleins are broken or split. They are destroyed. So thereby, the cells will lose attachment between the 2. And hence the cells will become loose like this. Cells will become loose like this. And those loose cells which are there in the vesicle. When I am telling vesicle, I am talking about here the histopathology. In that split space, if I see those loose round cells, I will call it as acantholytic cells, or I will call it as Zank cells. Zank cells. Okay, so let us move on to the last discussion for today's discussion. A 26-year-old female presents with a gradually enlarging, painless, bony hard swelling in the anterior mandible, extending from the area of tooth number to 23226. Radiographic examination reveals a well-demarcated radio-opaque lesion with a mixed radiolucent radio-opaque appearance, suggestive of intraosseous growth. The swelling is firm, fixed to underlying bone and has caused displacement of the adjacent teeth. What will be the probable diagnosis? If you see, first of all, mixed radiolucent radiopacity is there. First of all, mixed radiolucent radiopacity is there in the clue, and they have given a swelling in the displacement of the this one adjacent teeth has caused. Okay, so typically if you see, this is a case of central ossifying fibroma. Central ossifying fibroma. So basically central ossifying fibroma is a neoplasm. You have to differentiate between the ossifying fibroma and fibrous dysplasia. Why? Because fibrous dysplasia typically is typically a you can call it as a developmental condition, like condition. Okay. However, central ossifying fibroma is a neoplasm, true neoplasm. It's a benign neoplasm where you will see the mixed radiolucent radiopacity in course of progress. As the lesion enlarges or as the lesion progresses, the lesion becomes completely opaque. Okay, that is why there is one more MCQ. What is the typical radiographic feature of ossifying fibroma? Means you have to write down unilocular radioopacity. Is a typical radiographic feature of the central ossifying fibroma. Central ossifying fibroma. Okay, that completes the discussion for today's. So I hope this discussion would have definitely helped you people. We have gone through the maximum questions whatever possible in a short time, and I have tried to explain each and every question here. Okay, so that is why that is why in INICET papers and all these things, usually there will be a lot of repetition. So previous year PYQs or previous year question solving is very, very important. You should be thorough with them. And definitely it's not like all PYQs will come, but by solving the PYQs you'll get a better idea. Okay, so thank you so much, students. So keep studying, focus, and have a proper goal. Your goal should be fixed. Till that you achieve your goal, you need to do complete homework, full dedication. Any doubts? We are all there. We the faculty are all there for your doubt clearing sessions. Okay, thank you so much.